Hey, let's talk about the GI system. So, lots to think about here. I'm going to talk about a few things that are not exactly medication related, but involve a lot of supplements, so something to think about. If somebody has undernutrition, we don't see it very often, unfortunately, with the obesity issue in this country. But if they do, then sometimes it's an intake issue, and then you just give them Ensure. Sometimes it's an absorption issue. Those kinds of things aren't going to help that at all. And then sometimes it's a utilization issue in which they just don't have enzymes to break things down, cystic fibrosis, some other things can do that. Obviously, lots of things can do it. Treatment, dietary, we can put tubes in, or we can give it parenterally. So those of you that are going to be doing acute care will obviously be having to do a lot of management. For people with TPN, the reality is that the majority of this is done by the pharmacy, but it is something that obviously you're going to have to be aware of and take some responsibility for as well. Dietary. Um, Lots of things. We really try to get people to cut their carbs now, but we also need to make sure that people are getting the right vitamins. And I think my latest crusade is trying to get people to have the right trace minerals. I think we have a lot of people that have zinc deficiency. Diabetics pee out their zinc. I think a lot of people are low in iodine because we used to get iodine from fish. We don't eat as much fish. We used to have iodized salt. So that's my most recent crusade. Not a lot of hard data that necessarily supports me on this, but something that I invite you to look into as well. Again, things that we can do, NG tubes, gastrostomy tubes, jejunostomy tubes are used more if it's long term, just because the issue of reflux is less. Usually those people, the gastric juices are coming down into the duodenum and still providing nutrition and digestion. When you give it into the jejunum, it's obviously usually backing up into the duodenum, but not necessarily all the way into the stomach, so they don't have as many problems with vomiting. Parenteral, we've talked about this already. PPN can be given if you have low concentrations of sugar. Unfortunately, you really can't go much above D10. And unfortunately, that's often not usually enough to meet people's caloric needs. Overnutrition, obviously obesity is a major issue. I think it's a social issue and should be addressed as a social issue. Unfortunately, we rarely have groups of people sitting in front of us. We usually have individuals. And so we often have to help them individually and try to figure out ways that they can alter their own nutrition. So anybody that's greater than 20% over ideal body weight, we have to be careful because we usually use BMI, which is something of a blunt instrument. If someone has mostly muscle mass, that's a very different situation than if they have fat mass. But I usually do BMI as a screening. Then if it's elevated, I look at the waist size and look at the person. If they look like they've got a lot of muscle mass, I don't worry about it quite so much. Obviously, obesity is associated with diabetes, hypertension, back pain, cholecystitis, and large heart. It's very simple. All you have these people do is eat less and exercise more. It's amazing. People, you tell them this, they say, I've never heard that before, except the 7,000 times that I have heard it before. There is no one in the world that doesn't know that that's what they should do. The problem is that we really are not very effective at helping them do that. I think that a low-carb diet is probably the best thing to do at this point because not only does it decrease calories, it also decreases stimulation of insulin. Decreasing stimulation of insulin decreases appetite. So there are medications that we can use in people that are particularly refractory. Unfortunately, a number of these medications do not have great evidence for long-term weight loss. Stimulants, we used to use fen-phen, which was phentermine and fenfluramine. There were 8 or 10 people that got heart failure associated with that. So rather than use it, we took it off the market, even though probably tens of thousands or more die of obesity-related issues, but we took it off the market. So phentermine is still on the market. It is a stimulant. I actually prescribe it occasionally if I have somebody that I've tried lots of things and they haven't been successful. And to be honest with you, most people that come in have tried half a dozen or more diets. Some people get a placebo effect, I think, by you're telling them this will decrease your appetite and this will help you. I've had people lose 70 or 80 pounds, although the evidence seems to be that this is not a sustained weight loss, and thus a lot of people don't like to use it. This is something that is controversial because some people will keep putting them on phentermine every time they gain back. If they've lost 80 pounds and they gain back 20, they'll put them on again until they get back to their goal weight. Is that good to have that kind of yo-yo dieting? Probably not. On the other hand, if you're keeping them down below their highest weight, maybe there is an advantage to it. There's also some appetite suppressants. Topiramate is Topamax, which is a medicine we use for seizures. We use it for migraines. We use it for all sorts of different things. And it is used often in combination with phentermine in something called Qsymia. The Qsymia is obviously a lot more expensive than using them separately, but it does have a lower dose of the phentermine than the regular phentermine pills. Liraglutide is actually a GLP-1 medicine. It's actually Victoza, but at a higher dose. And we know that Victoza usually will cause weight loss and act as an appetite suppressant. And so the Saxenda seems to be a very popular medicine now. They have fairly good evidence, but we'll see how it actually works out in the public. There are people that will use surgery like the Roux-en-Y, which is the true gastric bypass. Unfortunately, those people have, substantial dietary restrictions after. The gastric sleeve, they have less restrictions. They don't end up with a B12 deficiency like the Roux-en-Y folks do. It's something that they seem to have less side effects, but it also seems to be a little bit less effective. GERD, gastroesophageal reflux disease. Lots of patients know about GERD. Basically, it's a sphincter problem in which the upper esophageal sphincter, the lower esophageal sphincter allows acid to get from the stomach into the esophagus. And so if we can either increase that sphincter tone, which is very hard to do, or we can decrease the acidity of the stomach contents, we can decrease the negative effects of the GERD. There's some patients that will actually have so much reflux that the lower esophageal cells turn into stomach cells. When one type of cell turns into another type of cell, that's called metaplasia, and we know that metaplasia is associated with a higher risk of cancer. And so, therefore, these patients who have what we call Barrett's esophagus will often be put on lifelong treatment with anti-acid medications. So the GERD often causes heartburn. The sensation that comes up into the back of your throat is actually technically called water brash, but a lot of people have chest discomfort, they'll have cough at night, they'll have sore throats, lots of symptoms that you can get from GERD. But the effect of GERD can be substantial. You can actually end up with strictures in your esophagus in which you can't swallow things, it gets caught. There'll be scarring of the esophagus. And as noted, those laryngeal symptoms of the sore throat or even hoarseness can occur. So diet, you can try decreasing acidity. Some people find that soda is a problem. Some people find that really strong coffee is a problem. If that's all they need to do, then that's what they should do. H2 blockers, which are histamine 2, right? So histamine comes in 1 and 2. Histamine 1 is the one that's usually in your skin that causes you to get hives, that causes you to swell up. Histamine 1 is usually the one that's in the nose, in which you get swelling up of the nasal mucosa if you have allergies. H2 is usually found in the stomach. Maybe about 5% is found in the skin, and so if you have somebody with certain types of skin problems, you will use an H2 blocker. But predominantly we use this H2 blocker to lower acid. It only works in that one way, by blocking H2. Proton pump inhibitors actually block it in 3 other ways. We don't usually use them with H2 blockers, but they don't really effectively block histamine. So if you have somebody that you're trying to block histamine in the periphery, PPI won't do that. They're more effective, but they're also more expensive, and they also have more theoretical side effects. They decrease the amount of calcium absorption because they lower the gastric acidity so much that actually is they raise the pH. If they lower the acidity, they raise the pH enough that you won't absorb calcium as well. So there is the theoretical benefit of osteopenia or osteoporosis. There is also a statistical association between people that are on PPIs and people that develop dementia. We don't know whether the PPIs cause the dementia, whether the dementia in its very earliest forms cause stomach problems, or whether there's a gene that causes both. We really don't know, but we do know that there is an association. So a lot of patients would like to get off them if they can. There is surgery for GERD. It's called a fundoplication, in which we tighten up that lower esophageal sphincter, but that's usually kind of a last resort. So the diet: lower your acid, avoid your coffee. There's pretty variable value to it. Some patients swear by taking cider vinegar in the evening, and they've gotten off their medication. Not a whole lot of data about how that works, but it is kind of an interesting phenomenon, and I probably have at least 24 patients that do that instead of a medication. Gastritis, gastrostomach, itis, inflammation. Gastritis is usually an inflammation of the stomach, usually caused by a virus. Also can be caused by NSAIDs. So just to keep in mind that some of the other medicines that we give may be causing GI problems. Caffeine can cause it, alcohol can cause it, lots of things can cause it. If the irritation goes too deep and erodes through that upper level, it basically causes an ulcer in that level. So you think about ulcers in the skin, breaks in the integrity of the skin. This is a break in the integrity of that inner lining of the stomach or duodenum. It's pretty rare now, just because usually patients will start themselves on these medicines, but it is theoretically a possibility. If someone does get an ulcer, we will test them for a certain bacteria called Helicobacter pylori. And then treatment for that, since it is a bacteria, would include certain antibiotics and also raising the pH, i.e. lowering the acidity. Severe stress can also cause ulcers, but not usually. We used to think that most ulcers were caused by people just being stressed in their life. Not usually. Peptic ulcer disease, as we know, you can also get bleeding. This is one of those things with NSAIDs. You can get bleeding as the first symptom, so they may not even have any stomach pain, discomfort, which is one of the reasons that I am very careful in prescribing NSAIDs to patients. So you treat it with H2 blockers, PPIs, or antibiotics. So here's Joyce. She's 44 years old. She's Native American. She's got 3 kids. She's had a dull pain in her upper abdomen for a while, and it gets worse after eating. Similar to the pain that she had after her last child. And when we do an ultrasound of her abdomen, we see that she's got a lot of gall stones, and we see that those gall stones have caused some inflammation of the inner lining of the gallbladder. That's referred to as cholecystitis. Cholelithiasis. Lithiasis just means the presence of stones. And so she's going to go to the hospital for an elective cholecystectomy. These gallstones are usually, interestingly, mostly cholesterol. And this is why women get them way more than men, because female hormones cause women to clear their cholesterol out of their bloodstream, but it has to be excreted through their bile, and therefore they are more likely to develop gallstones. Men develop them too, and it's actually difficult because we assume men don't have them as much, so it's often a much more delayed diagnosis. These stones can obstruct the biliary tract, the common bile duct, and in that case, patients would become jaundiced and very painful. Gallbladder symptoms, usually in the right upper quadrant. Sometimes they can't tolerate a fatty meal. Jaundice is a late sign and a severe sign, and elevated white blood count, of course, is a sign. Now, Actigall, or Ursodiol, is a medicine that has been talked about for many, many years. It is available to dissolve gallstones. The problem is that it has more side effects and works so slowly that most patients will opt to have surgery. Now, there are a small number of patients who cannot have surgery that we might use the Actigall for. So it's good to know that it exists, but it's used very rarely. Because the surgery is now done through a scope, you don't have to open up the abdomen, you usually just do it through a scope. The recovery is very quick and pretty easy for most patients. Some patients need to limit fat after their cholecystectomy. Many don't, interestingly, but if they do, they learn that it bothers them, they just don't eat it. Diarrhea. So to switch gears here a little bit. So diarrhea is a common problem that we'll deal with. So basically it's, sort of increased frequency, volume, or fluid content of stools. And lots of causes: viruses, bacteria, parasites, malabsorption, certain medications, allergies, and people that are nervous will sometimes get diarrhea as well. Often refers to results in dehydration, low potassium, which we always know about, low magnesium, which we don't usually know about because we have to order a specific test for magnesium. It's not included in the normal electrolyte panel. They'll also lose some bicarb, which may cause acid-base changes. So what do? We can actually try to culture the stool. The problem is that many things don't show up in culture. Many things are unpredictable. There's certain laboratory testing, such as magnesium and potassium, those kinds of things we should look at. Most patients, if they have a mild diarrhea, you leave them alone and they get better on their own, and it's usually thought to be self-limiting. One thing you do need to be very careful of is that if a patient has diarrhea and they have been on antibiotics over the past few months, you really need to make sure that C. diff has been ruled out. C. diff, Clostridium difficile, is an infection of the colon that happens because other bacteria are gone and the C. diff overgrows. The C. diff irritates the inside of the colon, and it will cause something called pseudomembranous colitis, in which it will be a very mucousy, thick, disgusting stool that basically covers the whole inside of the colon and is so severe in some cases in which there's no absorption in the colon, and those patients become profoundly dehydrated and sometimes even die in certain parts of the world. So we don't want to slow down the process, because if we slow down the diarrhea by slowing the motility, there's actually even more absorption of those C. diff into the bloodstream, and they'll get a bacteremia and they become septic and can even die. So diarrhea, we try to limit foods, hold milk usually. The BRAT diet, the B-R-A-T diet, has been criticized by the American Academy of Pediatrics. There is no formal recommendation for the BRAT diet anywhere that you will ever look, but it still exists and people still recommend it. I think it's a very poor choice. I think it limits choices too much, but there are a lot of clinicians that will still recommend it. And then if you have somebody that has diarrhea, you can give Imodium. Imodium will slow down the gut. Imodium is basically got some of the same substances that stimulate some of the same receptors as narcotics do. And so, rarely people will even get addicted to Imodium, but it's relatively non-addictive and not dangerous because it has so mild effects, but does have pretty good effects on the colon. So what's constipation? The other side of the coin. So if you have someone who is not passing stools, or if those stools are extremely hard, although we usually refer to that as obstipation, then they may have constipation. Usually it's related to people that aren't moving around much. They don't have enough stimulation of their colon from physical activity. They don't have enough fluids in their system. Certain medications can slow down your gut. There might be an increased tendency with age, but there's lots of elderly people that don't get it. If it's bad enough, they can actually get a complete blockage in their colon and can develop sepsis and die. So if you've got somebody with constipation, you try to find the cause. You look through all their medications. You talk to them about their fluid intake. You talk to them about their diet. You try to get them to increase their fluid and roughage in their diet. Laxatives are usually necessary if someone's constipated. Stool softeners are very interesting. There's not really any research that supports the use of stool softeners, but they are continued to be used. Basically, they're a surface active agent like soap. So if you use something like Colace, which is docusate, it is almost the equivalent of soap. To be honest with you, we're using it right now as a cleansing agent for my dog's ears. It is, I think, a controversial thing, although many people will continue to prescribe them. There's other things. A bulk forming laxative is usually the one that is best used if you're using it long term, something like Metamucil. Osmotic laxatives like milk of magnesia also work. Miralax probably creates a little bit of bulk because it is a good amount of fluid, and it does have almost a little bit of a fiber effect, but it also draws fluid into the gut. These laxatives sometimes can create dependence. There are people that can't seem to go once they start on milk of magnesia or Miralax. Irritant laxatives like bisacodyl, which is Ducalax, can be used as a suppository or can be used as pills. It basically irritates the colon and forces it to become hypermodal, and then you defecate. Enemas obviously can either be osmotic, something like a fleet enema, which they put high salt content up into the rectum and it draws fluid into the rectum, or something like a soap suds enema, in which it's a lubricant effect. So this slide does kind of talk about those things that we just talked about: the stool softeners, the lubricants, the hydrating agents, stimulants, and then there are other medicines that are used for people with chronic constipation related to narcotics that basically are prostaglandin medicines. I'm going to let you learn about those when you learn about some of the other things that you'll be exposed to in your med-surg rotations. But these are relatively new medicines and are used in very specific instances. All right. So gastric ulcer, again, NSAIDs, NSAIDs, NSAIDs. Duodenal ulcers, same as gastric ulcers, although they usually cause their pain a few hours after eating, not with eating. We also can use a coating agent like Carafate. And that basically is like a Maalox or a milk of magnesia. All of those basically coat the stomach or esophagus or the inside of the GI tract. Bismuth, which is Pepto-Bismol, is the same kind of thing. Interestingly, Pepto-Bismol has aspirin in it, or at least a salicylate. So therefore, we do have to be careful to make sure they don't get excess amounts of that, because that can potentially irritate the intestines as well. Obviously, if somebody's bleeding a lot from an ulcer, they'll get blood transfusions and be in the hospital, but we rarely see that anymore. So ulcerative colitis and Crohn's, these are inflammatory bowel diseases. Note the spelling of Crohn's. I'm a spelling Nazi, as you well know, and I really think that it's very important to spell it correctly. Crohn's affects anywhere from your mouth all the way to the rectum. Ulcerative colitis is just in the colon. The treatments for Crohn's, they do an anti-inflammatory type medicine such as aminosalicylate or budesonide. The next step is another anti-inflammatory such as a corticosteroid. Tumor necrosis factor is a substance which is secreted in cancers and a lot of inflammatory processes. And so sometimes we'll use methotrexate to block that directly. The other thing is we now have these MAB drugs, these MAB, these monoclonal antibody drugs, which are very specific for TNF, and they will take the TNF out of the system. So Tisabri, natalizumab, and there's 3 or 4 others, Humira, there's a bunch of them that will actually take this TNF out of the system and decrease the inflammation of Crohn's. Ulcerative colitis, very similar. So aminosalicylate, that anti-inflammatory. Then you move up to corticosteroids, prednisone for flares, and we also can use, longer-term similar drugs. The anti-TNF will often use cyclosporine or thiopurine. For these folks, we can also use those MAB drugs. They're not used as much for ulcerative colitis. Just because they're not quite as specific, but they are definitely an option for them as well. And in extreme cases, since it is just the colon, we can sometimes remove the entire colon and the person ends up with an ileostomy. It's an extreme case, but I've actually seen some people that we had a really hard time managing. Now that we have the option of those monoclonal antibody drugs, I think that's going to become extremely rare. And again, here's your drugs of the week. Post on the discussion board, and I'll see you at the next class.